and you have the myocardium in between. And then with the normal flow, you can see that the blood just goes through the myocardium and is taken from the venous and goes to the outflow. And when there is occlusion, that music which is playing, when there is occlusion, you can see that this area becomes ischemic. Now, we all know that when ischemia occurs, basically the pH decreases. So there is acidosis and the potassium significantly increases. So one of the most important things which determines the current of injury is the potassium in the extracellular place, which actually increases. So this is a cartoon again to show you what actually happens once the myocyte becomes ischemic. You can see that within the cells, the ATP decreases, the creatinine phosphokinase decreases, the pH decreases, whereas outside, the potassium ion increases, the carbon dioxide increases, and the lactate increases. The other ones you need not worry, but important is that there is a significant amount of acidosis which is induced by ischemia. So during the period of ischemia, if you see the text which is written here, within 5 minutes, the potassium rises. So the potassium begins to rise within seconds of onset of ischemia. Within 5 minutes, it rises to levels of 18 to 12, and then it remains like that for about another 15 minutes. Then again, it increases to around 20 for about 40 minutes. So the rise in extracellular potassium leads to a decrease in the resting membrane potential. So what does it mean? So here, if you see, you can see the rise in potassium. Initially, there is a rise. Then for a few minutes, it remains static. And again, there is a rise in potassium once ischemia starts. Now, just going back to some basic physiology, we know the depolarization potential, the resting depolarization is around minus 85. And then you will have the phase 0, phase 1, phase 2, phase 3. So you can see that it starts from minus 85 and then overshoots and then starts coming down. All of us know that the sodium current, the potassium current, and the calcium current, these are the three main currents which actually cause this particular action potential to occur. Now, this is basically within cells which do not have too much of atomicity. So these are the myocytes where you will have a depolarization which is resting at around minus 85. Now, when potassium ion increases, all of us know that potassium is a positive ion. And so K plus, so potassium is a positive ion. So the negativity decreases. So instead of minus 85, now the resting potential comes to minus 65. And over a period of time, then it further decreases and comes to minus 45. So the baseline at which the membrane potential is stagnant, it starts going up because the potassium is increasing. So this is again to explain to you that in the center you have the infarcted segment, then outside you have the normal segment. In between these two is a borderline segment, which is ischemic. So here the potassium levels are intermediate. So if you look at PCO2, you can see that it is normal here, slightly more here. Maximum in the infarcted segment again comes down. PO2, we know it comes down. Similarly, the potassium is slightly high in the ischemic segments and maximum in the infarcted segments. So what happens to the potassium? The potassium, because the lactates have increased, the acidosis has increased, the pH has decreased, the potassium in the extracellular compartment is going to go up. So the maximum is in the infarcted segment, less in borderline, and normal in the normal segment. So the resting membrane potential, which is minus 85, goes up to minus 60, and over a period of time, it goes on to minus 45. So if you look at the infarcted segment versus the normal segment, there is a difference in the action potential. So because of the increase in the potassium ions, the baseline, so the red is the infarcted area. So the blue, which is at baseline, is now going up. So instead of minus 85, it goes to around minus 65. Similarly, the overshoot comes down because the potassium is on the higher side. And then there is again a gradient between the phase 1 of the action potential of the infarcted segment and the normal segment. So there are two places where there is a gradient of current whenever you have ischemia. Now, fundamental in understanding the current of injury is that the current always goes towards the more negative pole. So if you have a minus 65 and you have a minus 85, the current goes from minus 65 to minus 85. So from less negative to more negative. That is where the current of injury moves. This is actually a paradigm shift because initially when physics started and voltage and all came, they thought it goes more towards positive. But later it was found that it goes towards the more negative pole. So from less negative to more negative, that is where the current flows. So now let's see how the ST elevation occurs. So this is the normal QRS complex and the normal action potential. So red indicates the infarcted segment, blue is the normal segment. Here there is no ischemia. So this is normal. The vessel is flowing. So you have the action potential producing the QRS complex, the depolarization, and then the repolarization. So the action potential correlating with the ECG. Now, when you have an infarcted segment, we know that it goes from the subendocardium to the epicardial surface because this is the most prone area. Always the inner surface gets ischemic first and then slowly progresses to involve the entire myocardium. So it produces a transmural infarct over a period of time. So let us see at baseline what is happening. We mentioned that the current basically in the infarcted segment, because the potassium is more, it is now at around minus 65, whereas outside the baseline is minus 85. We also mentioned that current goes from less negative to more negative. So now from the infarcted segment, the current is going away towards the normal segment. So the TP segment, that is before the QRS starts, the segment which is there is a gradient where the blue is normal, this is minus 85, the red is minus 65. So there is a gradient between these two. This gradient is producing a current which is going away. So if this is the baseline, you look at here, you can see that the line is on the baseline. The ECG is coming at the baseline. Now, because the current is going away, what is happening? The baseline has come down. Okay. So the TP segment has come down below the baseline. Now, once the action potential starts, again, there is a gradient where you can see that the outside, the action potential is around zero, but in the infarcted segment, the action potential is somewhere around minus 20. The opposite occurs during depolarization. So this gradient is now producing a more negative current in the infarcted segment and less negative current in the normal segment. So the current is going to flow from 0 to minus 20 because this is more negative. Okay. So now this causes the current to go from the normal to the infarcted segment. Your lead is here. So now the current is going towards the lead. Because the current is going towards the lead, it will produce a ST elevation. So what you see in the ECG is a combination of a ST depression of the TP segment and a ST elevation. Both together give you the impression of ST elevation. So that's how the ST elevation occurs. So this is the concept of current of injury. So during infarct, transmural infarct, you are having a current from less negative to more negative, which is producing the ST elevation. Now, what happens when there is ischemia? So this we just mentioned that when you have an infarct during the baseline, the current is going away, which is producing a TP depression. During the depolarization, the current is coming towards, which is producing the ST elevation. Okay, so this we just explained to you. Now, what happens when it is a subendocardial ischemia? So now when you are having a subendocardial ischemia, we know that the during baseline, the current is again from the infarcted to the outside segment. So the TP segment goes up. And during the depolarization phase, the current is, this is 0, this is minus 20. So now during depolarization, the current is going from 0 to minus 20. It is away from the lead because there is a normal segment between the infarct and the lead. So this normal segment, the current goes from 0 to minus 20. So the current of injury is now going away from the lead, which is producing the ST depression. Okay. So whichever in this entire area, wherever you place the lead, the current during depolarization, will show ST depression because across this area during depolarization, the current is going from the normal segment to abnormal segment. Okay, so that is the concept of current of injury, and that is the concept of how ST elevation occurs. Is it clear? Anyone has any doubts or comments on that? Sir, you want to add something?
No, only thing is, it's not infarcted yet. It is ischemic, active process. Once infarction is completed, the ST segment settle down to baseline.
Yeah, this is the wave of injury, the wave of ischemic injury. Yeah, someone wants a repetition of ST depression. See, ST elevation, if you have understood, ST depression becomes easy. So in ST elevation, this entire area is ischemic. Okay, when the entire area is ischemic, the current can go from either side. So from either side, during baseline, it is coming towards ischemia. During depolarization, it is coming towards the lead. Okay, so we mentioned that TP segment, that is initially the current is going away. This is minus 65 and this is minus 85. So current is going away, which is producing a depression of TP segment. Now, during the depolarization phase, the gradient is outside, it is zero. So it was minus 85, now it has gone to zero. This is around minus 65, it remains at minus 20 during depolarization. So now the current is coming from 0 to minus 20. So because it's coming from 0 to minus 20, during the action potential phase or the depolarization phase, you are getting a ST segment elevation. But here it is because the whole muscle is ischemic, and from the normal it is coming to ischemic segment. There is no normal segment here. But if you have a subendocardial ischemia, there is a normal segment between the infarct and the lead. So the same thing is happening. During the normal resting phase, this is minus 85. This is minus 85. This is minus 65. So the current is going from here to here. So it is producing the TP segment elevation. Okay. But when the patient is having depolarization, what we showed in infarct, suppose you look at here infarction, it is the same from normal to ischemia during baseline, from normal to ischemia during depolarization, from ischemia to normal during baseline. The same thing is happening in subendocardial ischemia also. So during baseline, you are having a current which is going from minus 65 to minus 85. And during depolarization, the current is going from 0 to minus 20. Okay. The same thing is happening, except that now previously the normal segment was here. So that's why the current was coming towards. But now the normal segment is in between the ischemic segment and the lead. Okay, so it causes the exact opposite of ST depression. So now because from normal, it is going towards the abnormal segment. During depolarization, it produces the ST depression. So if you just understand the diagram, it is easy to understand the concept. Is it clear for everyone, the concept of current of injury, why it occurs? Ashish?
Yes, sir. Clear.
So this is very fundamental for your understanding. So at least at MD level, DM level and all, if somebody asks you, you should be able to explain how this occurs, what happens to the potassium ions. In normal action potential, what determines the phase 0, phase 1, phase 2, and how this particular change in potassium produces the gradient between the normal segment and the ischemic segment. And that produces the current of injury. So then we'll continue with our presentation if you have understood this concept of current of injury. Sir Kumar sir, anything you want to add?
No, Raju.
Okay, sir. Able to see the screen? Okay, so we had mentioned, we started with discussion of ischemia and infarction. We mentioned about the 16-year-old girl who had a tight left main and would have almost died if that ECG was not suggestive of a left main stenosis, and intervention would not be done. So what we'll discuss as far as ischemia is concerned, many questions were asked yesterday about Barbosa criteria and all that. So we'll talk about how we recognize ischemia infarction, patterns of ischemia infarction, MI terminology, and what are the ECG mimics. So ischemia generally is a decrease in blood supply and it produces ST depressions and T-wave inversions. Whereas infarction is the death of the muscle. So by definition, if you say infarction, it means that that particular area is dead. Okay, so you should differentiate between ischemia and infarction and is recognized by ST elevation. So we already mentioned about what the different waves are there. And this again explains what we showed you just now. So when you have ST subendocardial ischemia, during depolarization, the current of injury is going away, so it produces ST depression. Whereas when you have a transmural infarct, then the current is from the sides or from behind, and it is going towards the infarcted segment that produces the ST elevation. So the patterns of ST depression we again mentioned to you while describing. So there will be some overlap slides. Then infarction patterns we mentioned about how you can mistake certain cases for broad QRS complex. So now the question is, what do you think this is? This is a broad QRS or is it ST elevation? You can type your answers or you can unmute and let me know. This looks like a LBBB or it looks like a ST elevation. What is it? So Ashish felt it is ST elevation. Anybody else? See, give a wide guess. You will be 50% right. Either it is yes or no. So type something, yes or no. So two people are for ST elevation. So ST elevation is winning the polls presently. Anyone else feels it is broad QRS? Okay, so it's nice that all of you have mentioned ST elevation, but the reason why I put this ECG was because I got a call saying that the patient has a very broad QRS complex. And what to do with that? Patient is on beta blocker. Should we stop the beta blocker? So that was the question. So if you look at the ECG here, okay, you can see here that this looks significantly like a broad QRS and people get confused. Now, how do you differentiate whether it is broad QRS or ST elevation? One is, of course, you are a genius and you need not bother about anything and you say like, few of you have answered, right, that it is ST elevation. But for normal mortals, if you see this, you can see that you see the other leads. See this QRS complex, it is narrow. Okay, so in L2, in L3, in V4, in V5, V6, you can see that QRS is narrow. Only here it appears to be broad. So it is not possible that in one lead you are having a narrow QRS complex and the other lead you are having a broad QRS complex. And this segment, suppose you have a L2 long strip, this is a nice demonstration. So these are all simultaneous tracing. So if you take this particular line, that is the QRS, okay, and now you can see that this is the ST depression on lead 2. You can clearly see the ST depression here. So this ST depression is correlating with this ST elevation. So that means what you are seeing here is actually ST elevation. It is not part of the QRS complex. The second clue is you generally won't have such a broad QRS complex. Very unlikely patient will be alive with such a broad QRS complex. So don't fall for broad QRS complex, look at the entire ECG, and then you'll be able to identify that what you are talking about is ST elevation and not broad QRS complex. Trust me, many of you will commit this mistake of mistaking a MI for a broad QRS complex. Okay. Then you should know certain terminology in myocardial infarction, what it means. So we mentioned that when you have ST elevations in L2, L3, and AVF, then it is a inferior wall STEMI. So MI or ischemia is dependent upon whether you are getting ST elevation or ST depression. So if you have it in lead 2, 3, and AVF, then it is an inferior wall MI or ischemia. Now, generally, inferior wall MI is associated with posterior wall MI. So posterior wall MI is demonstrated by tall R waves with ST depression in V1, V2. We'll show you the example. So when you have a posterior wall MI, but it is not associated with the inferior wall MI. So generally posterior is associated with inferior wall MI. If you have a posterior wall MI which is not associated with inferior wall MI, then you call it as a true posterior wall MI. Okay, so pure posterior wall MI is called as the true posterior wall MI. RVMI is where you have ST elevations in right-sided leads, that is V3R and V4R. So we know that V1 and V2, V1 you keep it in the right second intercostal space, V2 in the left second, and V4 will be at the apex, and V3 is between V2 and V4. So the same position, wherever you have put V3, if you put it on the right side, that is called V3R. Wherever you have put the apex, the same thing you put it on the right side, then it is called V4R. So right-sided leads. That's why it's called R, V3R and V4R. Anterior wall MI we mentioned is from V1 to V6. Anteroseptal and anterolateral, generally those terminologies are no longer used nowadays. Extensive anterior wall MI is when you have ST elevations from V1 to V6 and also in L1 and AVL. So if lateral as well as anterior leads show ST elevation, then you call it as an extensive anterior wall MI. Lateral wall MI is L1 and AVL. Sometimes it is also called as high lateral wall MI. That is, you would, again, lateral wall MI is generally associated with anterior wall MI. The way posterior is associated with inferior, generally lateral wall is associated with anterior. If you don't have anterior, only lateral, then sometimes it's called as a high lateral wall MI. And there only L1 and AVL will show ST elevations. If you are suspecting high lateral wall MI, V4, V5, V6, you take one space above. So suppose if it is here, you keep the leads about one space above, and you might be able to identify ST elevations in the high lateral wall MI. Okay, so those are the terminologies. Then you come to the localization. So if you look at an inferior wall MI, you need the inferior wall MI could be because of a right coronary artery occlusion, or it could be because of a circumflex occlusion. So we said L2, L3 has AVF has ST elevations, it indicates inferior wall MI. Now it could be a right coronary artery which is producing it, or it could be a circumflex which is producing it. So circumflex from the aorta, the left main, gives rise to the circumflex and the LAD. This supplies the lateral wall, and the right coronary artery arises and follows the right side, right AV groove. So if you just look at me, you can, I'll just show you that if you look at the heart, okay, this is the lateral side. So circumflex is going on to the lateral side. So a circumflex territory infarct is usually like this. So the inferior and lateral. So it is towards this side. Whereas right coronary artery comes like this. So the infarct on the right side, the infarct of the RCA is on the right side. Okay. So now you want to differentiate this infarct from this infarct. So how do you differentiate? You look at the leads which will help you in differentiating. So what are the leads? L1 and AVL are towards the left side. Okay. L2 is more towards the left side, L3 is towards the right side. So these are the leads which will differentiate. So if I take L3, which is going towards the right side, naturally if you have we know L2, L3, AVF, all three will produce ST elevation. But if you have a L3, which has a ST elevation more compared to L2, that means it is a right coronary artery infarct. Similarly, if you have a ST elevation where L2 is going this way. So L2 is more than L3, then it indicates it is a circumflex infarct. L1 and AVL we said is lateral. So the current of injury is towards the lateral side. So if L1 and AVL are showing ST elevation, it indicates it is a circumflex territory. Whereas the current here in RCA infarct is going away from the left-sided leads. So L1 and AVL are showing ST depression, then it indicates that it is a RCA infarct. So this is what is shown in this particular diagram. Okay, so this is the right coronary artery. This is the circumflex. We know that lead 2 is in this direction, lead 3 is in this direction. So if lead 3 is more than lead 2, it indicates that it is a RCA infarct. Whereas if lead 2 is more than lead 3, it indicates that it is a circumflex infarct. Then L1 and AVL are towards the lateral side. So if L1 and AVL are showing ST elevation, it is a circumflex infarct. Whereas L1 and AVL are showing ST depression, then it is a RCA infarct. Okay, so if you understand the concept of current of injury, it becomes very easy for you to understand where exactly the abnormality occurs. So this is to show you how the infarct is on the right side in RCA and on the left side in circumflex. Okay, is this clear? Is this concept of differentiating RCA and LCX clear? Any questions on this, sir? You would like to add anything?
The inferior MI, as Dr. Rajiv said, circumflex versus RCA. Also be aware, circumflex supplies the posterior wall of the heart, which electrocardiogram, routine electrocardiogram don't have representation. The opposite changes when we expect it may happen in the acute phase or it may not happen, or even later. So a non-diagnostic electrocardiogram with a typical presentation of chest discomfort, etc., with a high-risk patient, a non-diagnostic electrocardiogram or even normal-looking electrocardiogram, a circumflex territory is important to look at. Then when you make a diagnosis of inferior MI, you are dealing with a proud politician or a businessman, what will you tell them? This we practice in exams institute. Don't tell them you have inferior MI, they get upset. Say it is the bottom of the heart, sir, small area, small infarct. Don't tell them inferior MI. So they get very upset that they have inferior, something inferior. Thank you.
How many of you think this is important? It has been put in the slide and we are discussing so much. It is because some examiner somewhere will ask you, or does it have any practical significance? How many of you feel it's important to know this? Okay, 2 people raise their hand. Three people, no, 4 people. Okay, so as luck would have it, just yesterday, 11 o'clock, we had one patient who came with inferior wall MI, and he had a right coronary artery which was totally occluded and obtuse marginal which was occluded. And in ECG, it was very clear. So one of our colleagues, Dr. Neelkant, was actually shouting, ECG shows RCA, ECG shows RCA, telling us that you do primary angioplasty to RCA and don't bother about the obtuse marginal. Okay, so because now once you have gone for the angiogram, of course, there are certain clues in angio which will tell you which is the acute occlusion. But suddenly in night 1 o'clock, you are taking up a patient, then 2 vessels are blocked. Sometimes both might be the cause of infarct. But now we don't know which one to open up first, which is the actual cause of infarct and the ongoing pain. So that's the time when ECG comes to the rescue. There are many times you come out of the cath lab and you say, please show us the ECG. You see the ECG and then decide which vessel to open up. So it's not without importance. It's a very useful sign in clinical medicine in decision making. And of course, always remember that RVMI, the right ventricular MI, V3 or V4 we mentioned, it always occurs with right coronary artery occlusion, not with the circumflex. So then we talk about the posterior wall MI. So if you see, you suspect a posterior wall MI when you have ST depressions in V1 and V2 with tall R waves. So if you can see here, you can see tall R waves. We said R wave should be miniature in V1 and V2, and you can see ST depressions which are there in V1 and V2. So a common question which students again ask is how do we differentiate these from anterior wall ischemia? This could be anterior wall non-STEMI versus true posterior wall MI. How do you differentiate? So the way you differentiate is the R waves. So in anterior wall NSTEMI, you will have ST depressions, but you don't have tall R waves in V1 to V3. If you are having tall R waves along with ST depression, that indicates that it is a posterior wall MI. So why is it a posterior wall MI? So posterior wall MI is one of the places where you give thrombolysis or you take up a patient for primary angioplasty, even though the patient doesn't have ST elevation. Why do we do that? We do that because the same thing I have reversed. Okay, the same ECG which you saw now, I have reversed it. So when we reverse it, V1 and V2, you see what is seen. Okay, you have a Q wave with a ST elevation. Okay, so once you reverse the ECG, you see a Q wave with ST elevation. Why are you seeing that now? Basically, posterior wall means it is behind, and now you are taking the leads from the anterior part. So when the current of injury is going behind, you are getting ST depression anteriorly. The same leads, if you would have put posteriorly, you would have got ST elevations. So now what are we doing? We are taking a ECG from front, but then you are turning the ECG. When you turn the ECG, instead of ST depression, you see ST elevation. Okay, so that confirms that what you are dealing with is a posterior wall MI. Is this clear? Somebody yesterday asked about posterior wall MI. How you differentiate from anterior wall ischemia and how you diagnose a posterior wall MI. Why is it called posterior wall MI and why do you treat it as a STEMI? Because it is a STEMI, but it is a posterior wall STEMI, which is presenting as ST depression in anterior lobes. Is it clear for everyone? So you should not miss this. If you miss this, you might lose the opportunity of doing a revascularization strategy for a patient who has come to you with chest pain and STEMI. Okay, then you come to RVMI. So all patients with inferior wall MI, you should always take the right-sided lead. Again, very important because it identifies which vessel is actually the infarcted vessel. So it helps in localizing also. If you have a ST elevation more than 1 mm, it usually indicates that it is a proximal right coronary artery occlusion. If there are no ST elevations, one, it might have evolved. That means already because ST elevations in RV side are very transient. So it might have evolved or it is a distal occlusion of right coronary artery. If you have a negative T wave in right-sided leads, it indicates a circumflex occlusion. So it is like opposite of RVMI. So it indicates a circumflex occlusion. So RVMI again, right-sided leads helps us in localizing the vessel. So if you see here, you can see that there are ST elevations in lead 2, lead 3 and AVF. So it is an inferior wall MI. Now you want to know what is actually producing that. Lead 3 is more than lead 2. L1 and AVL are having ST depression. So you know that it is right coronary artery. Plus V3R, V4R is showing ST elevation. Okay, so this is a patient with right coronary artery. Plus it is a proximal RCA because the patient is having ST elevation in V3R. So that's how you localize the lesion. Then we mentioned about anterior wall MI, extensive and lateral wall MI. We won't go into too many details about localization in anterior wall, but one important ECG, which you should understand in anterior wall MI, is what is called as a QRBB, that is Q right bundle branch block. So in V1, you have a QR complex. You can see ST elevations V1, V2, V3, V4, V5, V6. So this is an anterior wall MI. But QRBB, if you identify, it means that it is proximal to the first septal. So if you have left main, you have the circumflex, and you have LAD. LAD has branches. The branches of LAD towards the lateral side are diagonal. Towards the septum are called the septal branches. Usually the first branch is the septal. So when the septal gets infarcted, then it produces a QRBB. So if you have a QRBB on ECG, it indicates that the occlusion is proximal to the first septal, or it indicates that it is a proximal LAD lesion. So these people have a bad prognosis. So if the patient comes to you in the ER with a QRBB anterior wall MI, you don't tell them that you are a superhero, you are going to open the LAD, patient will walk back in about 2 days or something. You might start doing the angioplasty, patient might arrest on the table or go back with severe LV dysfunction and might have bad outcomes. So during procedure also, you might land into trouble. So once you have QRBB, explain to the attenders that he may not do good in spite of your best efforts. So they should be ready for bad outcomes in spite of trying to give them the best possible treatment. Okay? So that's a bad prognostic sign if you have a QRBB on the ECG. Then the other classical ECG which you should know in anterior wall MI is what is called a wraparound ECG. So you can, if you have ST elevations in anterior as well as inferior, you can see here. So L2, L3 AVF has ST elevations, anterior has ST elevation. Generally, when you see this, you feel worried that it might be a very extensive MI and patient might have a very bad prognosis. It's the opposite, because this generally occurs because of a wraparound LAD. So wraparound LAD means, again, you have the left main and you have the LAD. A LAD which from the apex is turning around and you have a distal occlusion. So both the anterior as well as the inferior lead show ST elevation. So a wraparound LAD with a distal occlusion usually produces ST elevations in anterior and inferior leads. So the patients might actually do well with this type of a ECG. Second, again, the practical importance is when we are doing angioplasty, we have taken up for angiogram, and we see a distal occlusion, we might get a doubt that, okay, better leave it because it might be a very small vessel, it is the distal end of the vessel. But if you have a ECG like this, it indicates it's a very large vessel, it is a wraparound LAD. So you should open it up. You'll find that there is a large vessel which is turning around. Okay, so again, that has some practical significance, diagnosing a wraparound LAD. The other reason is when the patient has both anterior and inferior. So today morning only, Dr. Simeon was showing ECG where there were ST elevations in anterior, inferior. Then we got excited and told that this is a wraparound with distal occlusion. And then he said, we did the angiogram, sir, both LAD as well as RCA was occluded. Okay. So you can have that, right? So you can have both vessels occluded. That time it is not a very good sign, but more common than not, it is because of a wraparound LAD with a distal occlusion, which produces this particular type of a ECG. So then I think we'll stop here, and tomorrow we'll discuss about the ECG mimics. A lot of people had doubts about Garbosa's criteria, LBBB and all that. So this is in brief about the ST elevations which you get, the posterior wall MI, how you identify, what are the common mistakes which are done, and how these ECGs help you in decision making and management strategies when you see the patient. So any doubts or any questions on this? Sir, any comments from your side while others get ready with their questions?
No, let them have any doubts. They can.
Vamshi, you raised your hand. You want to ask something? Are you guys able to understand anything what we are talking, or you are shocked what all has been told?
See, while they are thinking and to ask anything, it's very important when we initially were exposed to cardiology and electrocardiogram. The only test a cardiologist did in 1960s was 60s to 70s was their electrocardiogram. Pure new electrocardiogram was called a cardiologist. Whoever owned an ECG machine is also a cardiologist. Those days. So we used to think the purpose of the heart is producing an electrocardiogram those days. So then we realized later purpose of the heart is not electrocardiogram production, but it is pumping of blood. So that concept didn't die out. Today we have a branch called electrophysiologists. They again restarted that concept that purpose of the heart is producing electricity and electrophysiology for them. They make a survival on it, and they extirpate all the things that emanate from the heart as electricity, and it has become a branch now. So it's revived. And actually, interesting thing about this is what I am saying about electrophysiology and electrophysiologists and their beliefs. The recent edition of Braunwald and electrophysiology, the introductory page on electrophysiology, the author mentions this about electrophysiologists and their beliefs. Okay, please carry on.
It used to be a very prestigious thing to read a ECG. Somebody just, and we used to have those long ECGs, so a single lead ECG, single channel rather, single channel ECG. So people used to have a tie and all that, and then take a ECG and then go on seeing like that. Everybody used to look at them in awe and then waiting for some great diagnosis to come out. I also remember one instance when one of my classmates, he was quite intelligent actually. He's now in US, and that guy, he knew about ECG. During our time, ECG was not part of the curriculum, so we didn't have to read ECG during MBBS time. So one of our professors was trying to see the ECG and then again showing off similarly, medicine professor. And then this guy waited. Finally, when it was over, he said, "Sir, you are holding the ECG the other way around," and then turned and gave it to him. So some people used to just see ECG even without understanding, just to show off what they are doing. Okay, any questions from anyone? Sir, we'll go to book reading. Sir, you are in mute, sir.
I'm supposed to show them the mission statement.
Yes, sir.
Yeah, can I share the screen?
Yes, sir. Sir Kumar, sir, any comments?
No, I'm just curious to know what did the professor ultimately find in the upside down ECG?
He was very upset on the student.
Actually, it really happened, Kumar, it really happened because when you were MD, one of the days I'll present it. Actually, one of our colleagues, juniors, did the same thing in 1975, 76. Same thing happened with our professor also.
My classmate's name was Praveen Reddy. He is now a neurosurgeon, very famous neurosurgeon in US. Very intelligent fellow. So, he was very upset on him.
Shall I start this?
Yes, sir.
Mission statement BSR The Infinite Journey of Medicine. BSR Personnel Mission Statement BSR The Infinite Journey of Medicine. Great things have no fear of time. Chinese sage Teapot Medicine, the super science of humans. The secret of success in medicine is caring for the whole personhood of the patient, not merely the disease. Teaching the student, mentoring the junior colleagues, students sharing one's success, either recognition or material gains, with colleagues or rest of the team. They are our extended family. Today this teaching, mentoring, and sharing applies not only to doctors but across the whole healthcare delivery system. Our extended family involves all of them. Done this well, we can bring together multi-speciality, multidisciplinary teams to transform medical education and healthcare delivery. The basic requisite to be able to do this is the acquisition of symphony of profound knowledge, experience, and wisdom. Not only of medicine, but of all arts and sciences which make us human. The humility that we continue to be students lifelong in making all this possible and may never be attainable in one's lifetime. We live genetically through our children and grandchildren, but intellectually through our students and colleagues and some friends to carry this forward. This is an unfinished and infinite game of medicine. This great journey and unending game may never be achieved in one's lifetime. The secret of success in medicine is in caring for the person in every patient as a whole and not merely his disease or ailment. Teaching and mentoring the students and junior colleagues. Sharing one's successes, be it recognition, fame, or material gains, with it is our children and grandchildren that take forward our genomic structures, but our intellectual, academic, character strengths and professional legacy is carried forward on and on, by our students, colleagues, and friends. Some may leave, but others join. Start the great journey. It's never too early nor too late.
So this I wrote some time ago, and I have to update it, but I'll open it for discussion. Raju, take over.
These are all very inspiring statements. Actually, just listening to it and then feeling it gives goosebumps. As it is said, walking the talk, that is extremely important. So this, I would say, is more talking the walk, so which has already been done, that has been put in terms of words and sentences. So, because many of us have been fortunate to be part of that journey, it gives us goosebumps when we remember these statements, these mission statements. I think we'll have Kumar sir tell something, or will Sir Kumar sir, just hold on. We'll have students tell something first. I think they should talk.
No, Raju, can we repeat that?
Yes, sir. Sir, Kumar sir wants repetition of this.
Okay.
BSR Personnel Mission Statement. BSR The Infinite Journey of Medicine. Great things have no fear of time. Chinese sage Teapot Medicine. The super science of humans. The secret of success in medicine is caring for the whole personhood of the patient, not merely the disease. Teaching the student, mentoring the junior colleagues, students sharing one's success, either recognition or material gains, with colleagues or rest of the team. They are our extended family. Today this teaching, mentoring, and sharing applies not only to doctors but across the whole healthcare delivery system. Our extended family involves all of them. Done this well, we can bring together multi-speciality, multidisciplinary teams to transform medical education and healthcare delivery. The basic requisite to be able to do this is the acquisition of symphony of profound knowledge, experience, and wisdom. Not only of medicine, but of all arts and sciences which make us human. The humility that we continue to be students lifelong in making all this possible and may never be attainable in one's lifetime. We live genetically through our children and grandchildren, but intellectually through our students and colleagues and some friends to carry this forward. This is an unfinished and infinite game of medicine. This great journey and unending game may never be achieved in one's lifetime. The secret of success in medicine is in caring for the person in every patient as a whole and not merely his disease or ailment. Teaching and mentoring the students, patient as a whole and not merely his. It is our children and grandchildren that take forward our genomic structures, but our intellectual, academic, character strengths and professional legacy is carried forward on and on, by our students, colleagues, and friends. Some may leave, but others join. Start the great journey. It's never too early nor too late.
That's it, Dr. Kumar.
Thank you.
I think if people don't unmute themselves and start talking, we'll pick them up by name. So we'll start with Dr. Monica. Can you just give your comments, please?
I think I'm very small to comment on BSS sir's personal, but then having said, I'm very, very lucky that we work with you, Dr. D.N. Kumar sir, you, Rajiv sir, and BSS sir. The way you motivate us, the way you teach us, the way you take care of the patients is really inspiring, and it's very, very, very motivating, sir. It's always the moment for us to have learning with you people.
Thank you, madam. But this discussion was also about each one's mission statement. So we would want to know.
I think
what,
to be a
what
better
your
person,
thoughts
I
are.
think I'll stick with my initial statement to be a better person and continue the journey of learning for the betterment of the patients. I think I'll hold it to that. Maybe improvise as the day continues.
Okay, thank you. Thank you for
Thank you,
sharing.
sir. Thank you very much.
Dr. Rishika?
Yes, sir. This sir's mission statement was really inspiring.
1 minute, madam. Can you just introduce yourself?
Yeah, I'm a third year medical student from Osmania Medical College.
Okay, thank you. Go ahead. Go ahead.
For now, my mission statement is to keep learning and exploring new areas in this field of medicine.